எனக்கு அது தெரியாது. அவங்க சொன்னது அதுதான். அதனால பேங்க்குக்கும் வந்துட்டனால நான் அதுக்கப்புறம் பண்ண முடியல. அப்புறம்
Good evening, everyone. Respected Dr. Rahul Grover, sir, members of IATP, and dear doctors, we welcome you back for another episode Learn from Our Master series, organized by IATP. And yes, crossing 50 webinars is definitely an amazing journey so far. And I thank all doctors who are attending our webinars and other platforms like our Instagram and Facebook pages. We are very humbled to see your positive feedbacks. For those who are attending our webinars for the first time today, we will give you a brief introduction. We are the International Association for Dental Practice Excellence, a dental platform in which we believe quality education always ensure predictable outcomes of dentists of all discipline and abilities. Our organization is established based on the fact that dentistry is complex and require ongoing learning experience. We conduct various webinars and workshops to ensure and enhance the skill of dental professional and guide their dental journey. So, without further ado, let us start our series episode in which our topic of discussion is management of separated instruments in endodontics, given by Dr. Rahul Grover, sir. Dr. Rahul Grover is a microendodontist with 16 years of experience and specialized in magnification enhanced dentistry. He is a passionate teacher who takes lectures and CDEs at various platforms about the use of rubber dam and microscopes. He is a key opinion leader for Colting India. So, without any delay, I would like to welcome Dr. Rahul Grover, sir, and continue with the session.
Thank you, guys. Thank you so much for having me here. It's a pleasure. This is what I love to do. I love to teach, and I hope today that I am able to, you know, showcase a little bit what I do. And in this small time that I have, I can inspire you because, like, I was also here one day, listening to people, listening to mentors, getting inspired, making that tough call, doing the tough journey, embarking on it. And I hope some of you do it, most of you do it, all of you do it, and that is how I see this lecture going. So it's been a long time I've been on Zoom, and I've hijacked my kids' room here, so I don't know if they're going to barge inside or not. But guys, can you just help me out here? I'm going to just share my screen and let me know if it's the right time. It's almost 8:31, and I think we can start. Doc, you want me to wait for a minute or two? You let me know. All right, I want to. Just give me a minute here. All right, sorry for that snafu. I'm still trying to figure out. It's been a while, guys. Can you hear me? If you can hear me and if you can see the screen, can you just? I don't know if you guys can type on it? Can you just type a yes here? That's going to help me a lot.
So we could hear you and your screen too, but the presentation is not yet displayed, but the screen is there. Now it's like the
All
video
right.
is on.
All right. All right. All right. Doc, is that good?
Yes, doctor. You're audible as well as the screen is displayed with the presentation.
Fantastic. So, manage if there is anything participants want to ask or whatever. You just, I hope you're the one who's going to coordinating, so you can keep the questions and maybe I can answer it if we get time, or I can answer over a WhatsApp or on mail. So I'm going to start now, and this topic is. So first of all, I'm humbled to be here. All of you who have joined, it's an honor to be teaching, and I love teaching the most. I've been always been a teacher, and I used to teach in few colleges before I decided to jump full time into my clinical practice. And this topic is really close to my heart for reasons that I still remember in my postgraduate days. ProTapers had just launched. The ProTaper Universal had just come, and I ordered them. And it wasn't the curriculum at that time to get Rotary into ours. And those times I'm talking in 2005, 2006. Yeah, I was in second year. And I remembered my first case that I chose to introduce a ProTaper S1 was at the MB of an upper 6, and I separated it. And that was quite a moment for me. Imagine your HOD and your co-HODs and all your teachers looking down, and it seemed as if you're looking down a barrel of a gun at that time. And I was really scared of that ProTaper, and I did not know why it happened, because I was trying to do what was written. My speed was correct, my torque was correct. So, and this is not the first time I did something like this. So, as an endodontist, this is the hard part. This is where you got to face the hard facts that this separation is a part of growing up. The separation is a part of learning the skill. As you will play with more instruments, this untoward incident can happen, and my aim today is to make it sure that you follow certain steps and you take some precautions, that this is not going to be happening with you. Mind you, you learn a lot from it, and I learned my lessons quite early in my life when I did it, and it's a very embarrassing moment. So that's why I immediately jumped on when I was asked to take this topic. So here we go. Enjoy. This is a case I just recently completed about, I think, 2 days back. And that's how I just want to put this picture of this file that I retrieved from Muse Buckle of an 1/7. So it's like, doing a full circle. And it was 1/7 where I fractured, separated. And today, 1/7, I retrieved a file. Well, I should say I'm lucky, but there is always a method to madness, and I want you to, just listen and watch. Now you can take screenshots, record, whatever you want to do, you do, and I'll always be available on WhatsApp and an email to answer your queries. Now, here we go. Let's face the hard facts first, and here it comes. Separated instruments are usually due to the operator's errors. That's it. That's it. I'm going to just. This is a very profound statement. It is usually due to our errors, our operators' errors. Sometimes we do some miscalculations and all, and you end up separating a file. Very, very rarely you can blame it on the manufacturer that, hey, I did it. That's what I did. I said, goddamn ProTapers. It's because of you. It all happened. It wasn't because of the ProTapers. Yes, those ProTapers had issues, and to sort out those issues, because they were separating left, right, and center. And I still remember Dr. Cliff Ruddle came to India, and he had a lecture where he was trying to tell us, everyone, that why was it happening and what you need to do. And ProTapers evolved, and all rotary files evolved, and that's how the game goes. The most common causes are you are always overusing, or I might use the word abusing, your instruments most of the time, and the excessive force on the instrument due to an improper glide path. So in a nutshell, this one slide is all about how not to separate an instrument. Because if your glide paths are not correct, no matter what rotary you pick, remember this line that rotary files are followers. They are never the leaders. They're going to follow what you're going to give them. If you always keep this hierarchy in your mind, you will always be playing safe. If you think that just because a guy comes to your clinic and wants to sell you something and he says this is the latest, this is the best, this is the most selling in the whole universe and galaxies across, this is what you have to use and you don't need anything, that's not how it goes. Because most of the time we don't end up reading all the instructions, right, all the disclaimers. There are certain subtleties hidden behind these selling gimmicks. So always remember that rotary files are always going to be followers, they are never the leaders. And as long as you do that part and you make sure you have a good glide path, your rotary files will always be listening to you and will hardly separate. So what are there are certain things that you need to, keep in mind when you start a case. And so always remember, if you don't want to have this separation anxiety, so prevention is always the key here. And there are certain things that you need to understand, certain parameters, certain points that I've chosen that highlight that why prevention is the key. Now remember, a single patient instrument is always a very good choice. I mean, one can charge accordingly. These files don't cost much, but they cost a lot of headache and a lot of issues once you separate them. So I always prefer to have single patient instruments in most of the times. In cases which are difficult, like if I am doing an MB1, MB2 in a molar, and that's the end of it, I will not use my files again. But yes, then you have to charge accordingly. So this is one hard decision you have to make, how you see yourself practicing. How, you don't want to be going home with headaches and nightmares that something like this has happened. So try using this and you'll be more or less in the safe zone, not in the red zone. Always use light touch. Never force the instrument. That's very, very important. And always remember to go back to your glide path. So that's why I say glide path is the key. And I will not discuss glide path in much because that's another seminar to take, because it's the most important aspect. So remember, you have to have a good glide path. Just to tell you what is a glide path is if you take a 10 number file and you tap on the head of the 10 number file, the file slips to apex. That is your glide path. Now it's very easy to say that, a 10 number file slipping down. Yeah, it might slip down very easily, in a maxillary central incisor or maybe a distal of a molar. But if you mesobuccals MB2, it takes time to make that. That's why I said rotary files are going to be followers, never the leaders. Your most important file is that 6, 8, 10 in your pack. That's it. Those are the files that really, really set the tone for an easy endo or an easy endo made difficult endo by skipping some steps. And always work plenty of irrigation. Always make sure you're working wet. Now, how is that possible if you don't put rubber dams? So, one leads to another, and one skill leads to a learning another skill. I am taking a lecture today. That doesn't mean that I am an expert in this field. I'm still learning, and I still learn from my mistakes. And I still remember that I wasn't using rubber dams till 2014, and I was just doing the regular endo, and I wasn't doing the way I should have been doing. So that is not contemporary endodontics. That is not that was not the standard of care. So if you learn one skill, and if you want to become a master on that skill, you will realize that there are certain skills hidden within that one skill that you will have to learn. And slowly rubber dams came, then quadrant isolation came, microscopes came. So everything led to another. So this is my aim, that some of you, most of you, one of you gets inspired to take the next step, take the next journey. And that's how it works. So when you use plenty of irrigation, you will only be using it if you have good rubber dam practice in your clinic. And that is the most important skill you have to learn, so that you can, take the next leap. See, you got to be different. You have to stand different in the crowd. Everyone does endo. Most of you are doing endo. How are you different from the one practicing from the clinic next to you? That is the hard call you have to make now. And you are young guys, make sure you make that hard decision now, because as you will age, it's going to become easier as you grow into your practice. Another thing is that aggressive instruments with active tips, they end up causing ledges and they cause separation. So choose your instrument wisely. If most of the time in India, they they don't give you the best, they don't give you a new blister pack that, hey, this is your pack for demo, you use it. This is a new pack. So whenever you want to buy a file, take a file, take an extracted tooth and see how the file behaves in your hand. Think of it like your most important case, because you're going to be literally getting married to a new endodontic system, a new endo set of files for the rest of so many months or years before you change it. And honestly, I don't like to change my instrumentation much. I like to keep them simple because I know that it's cleaning and shaping. So once I shape, I need to clean properly, and for that I need more time with my irrigants. So keep your file system very easy so that you remember, your assistants remember, and always take a demo on an extracted tooth in a difficult, say a 6 or a 7, a lower or an upper, and see how the instrument behaves. If the instrument is grabby, it has an active tip and it tends to be sucked into the canal, then don't get those instruments. Look for a passive instrument. And in like in upper premolars, you will have these fins and isthmuses, mid-mesial. So be careful in those canals if you want to have lesser chances of separation. And you see, when I said one skill leads to another and another to another, so you will only be able to appreciate the fins and isthmuses of a canal if you have a microscope. So, and a very important part is that most of the times we do bind because there is dentine debris which is going to get clogged. So always when you bind, immediately back off. Don't try to push your rotary through it. If you have binding, that means there is a mismatch of the taper, or there is dentine debris at the apical part. So remember to always go back to your glide path, always go back to recapitulation, always go back to irrigation, because the most important files in your kitty today are the 6, 8, and 10s. They are the ones who will always steer you clear of any mishaps. So grabby instruments are the ones you should be staying away from. Pro tapers were really grabby, and because they used to have variable tapers, and of course that was their advantage also. A lot of people still use Pro Taper Gold. I used to use Pro Taper Gold, but now I have changed because they prep too much. I want to save dentine behind. I don't want to be prepping them to an 8% or a 9% F3s or F2s. So I steer clear of larger files because I want to save dentine. So make sure your hand tells you that this is the right instrument for you. So certain steps, these are the ones that I follow. Maybe you follow a few of them, maybe you follow a few of your own. So make sure you set a protocol for yourself. Remember, the key is access for success. Now, this line is so understated because in today's world of Instagram and social marketing, and you're putting up ninja access, small access, tiny access, really, really small accesses, you end up missing the main part. You end up missing the bigger picture, that if you don't have a good access, then there are very big chances your file will separate. The reason is these files are meant to cut root canal dentine. They are not meant to cut the dentine which is coronal to that, because the hardness number is higher of that. So you're only supposed to cut the root canal part of the dentine. So you need to have good access. That doesn't mean now in today's day and age of enhanced magnifications and microscopes that you start cutting larger preps, because the whole game is that if you don't leave too much of dentine behind, your good endo will also fail. So, but you need to have at least straight line access where you can see, and you're able to have direct access if you're working with naked eyes or even with loops. So make sure you access for success, and slowly from my loops to my microscopes, my accesses have become smaller. It is as simple as that. It was never that I had to, I used to make tiny access. So there will be a time when you have control over the microscope that you can actually make a smaller access and you're able to do justice to it. If you try to make a smaller access just because you want to showcase it that, hey, I did something something as small as a pinhole access, well, then there are chances you might end up failing. All through my presentations, I want to make one thing very clear. Some of this is just my opinion. This is just how I think. There are people who are much more skilled, have amazing skill sets. They will think differently, but this is what I can teach you in this 1 hour. Bite blocks. This is very, very important. Most of the times I used to initially think that why put a bite block in the patient's mouth, because the rubber dam is on, and you will realize that once you put a rubber dam, the patients are so comfortable that they start snoring and go off to sleep. And I have videos of them snoring, and I just recorded for fun. And I tell them that, you were snoring, and they was like, I never thought that during a root canal I can be so comfortable. So when they are snoring, there's a very big chance they will just suddenly close their mouth because they're in that moment of sleep. And once that happens, they're going to bite on the head of the, on that instrument, and it can separate very, very quickly, very easily. So remember to put bite blocks, good comfortable bite blocks, pen and good quality bite blocks have different types, different sizes for different age groups, how whatever comfortable jaw openings that they have. But make sure you have bite blocks, and make sure it becomes a protocol that you have a bite block placed under the rubber dam before you start doing your endo. Then always make sure the file is in motion when you're introducing it in the canal. That's very, very important. Constant movement will always help distribute stresses in the canal, and the file has lesser chance of separating. There are other, of course, I'm not saying that there are files that there is a technique called tactile control activation, which is something very different, where the file is not moving when you introduce in the canal. But those are for very special cases, not all of them. So make sure, as a beginner or as someone who's still practicing or who's still learning, you introduce the file when it is moving in the canal. So that's the time it should be introduced, not once you introduce in the orifice, then you activate it. So don't do that part. And most important, you always be prepared. Spend time on your x-rays. Take x-rays from 2-3 different angles. I always take 3 forms of x-rays: my mesial, angulation, straight, and distal, just to see how the anatomy is, what am I can look at. And if required, get a CBCT. If you're in doubt, always get a CBCT. So my rule of thumb is, as a referral practice, I get to treat patients who are being referred to me, and always understand, people don't refer easy cases. They're going to refer cases which they think they're headaches to them. So you're already going to get a headache into your clinic that are already coming with so much of baggage of bad endo and bad mouthing and so on and so forth. So if you're in doubt, always get a CBCT. That's the patient's prerogative to get a CBCT. If he doesn't want a CBCT, learn, or if he doesn't want that X-ray, learn how to say no before you get into you start a case and you end up repenting that, hey, I did not do my due diligence and now I can't do it. So be very, very upfront. And one thing that I can tell you to the beginners here, to the people who are practicing, just starting to learn practice, learn how to say no. Sometimes refuting that, no, this I will not start this case till the time you get certain things done, it makes sense. Learn how to say no if they're not going to pay you that well. So remember that you choose your practice and you define how you practice. It's never the other way around, because you will get all sorts of patients. So you want to go home with lesser headaches. That's my whole aim of teaching you today, or whatever I can teach you from my experience. Let's understand what a file. Doc, am I going okay? Am I going too fast? You can let me know. I can always go slow if that's required. Doc, you there? Can you hear me? All right. Hey, I think you're all there because I can't see much. I have my screen on. So, uh, cyclic fatigue versus torsional stress. This is very, very important. That understand what the file is going through in the canal, and once you understand what the file is going in the canal, you will be actually, like, you will realize how important it is to choose your instruments very, very wisely. Now, what is cyclic fatigue? Cyclic fatigue is what we do most of the time. It occurs when an instrument is not bound or is not bind in the canal, rotates freely in the curvature. At the same time, it is being subjected to repeated cycles of tension, compression, and it's moving freely. So this is a cyclic fatigue. Each instrument that you have, a rotary instrument, has a cycles of failure. And that's why it's called cyclic fatigue, that after certain cycles, it is bound to fail. Now let's see a video of a cyclic fatigue, what exactly happens. And what is torsional stress? Torsional stress is when the tip of the instrument is going to bind in the canal, but the motor keeps rotating it. So for example, there is a apical constriction, and you have clogged it, and now the instrument tip is in that, and if the tip is rotating, the file will separate very easy. So remember, it's the apical end, mid roots, where all these mishaps will occur. So torsional stress is the scariest of them all, because that means you have not understood what's happening, and the tip is locked in the canal, and the motor continues to rotate it. So first, let's see what is cyclic fatigue and how it happens. So as the file keeps on rotating, moving in the canal, so there are going to be cycles of uh, elastic deformation, compression on one side or the other, and slowly you will start seeing that there is going to be a failure. And that's how it. So again, same video, it's easy to understand here that this is what happens to all your files. That if you're, so these are the files that you're all the time reusing, it's going through a cycle of death. That's how it happens. And one fine day you file that the file has separated. Now torsional is when it is stuck and you keep on giving rotations on the head, and that's the time where the torsional fatigue will set in very, very quickly. Now this can happen with a new file also. This can happen with a new file, and that's what happens when the glide path is not formed. And that's what happens when you don't have a slip and slide 8 or a 10 number file to the apex. And torsional fatigue is real. I mean, you can separate a new file if this keeps on happening. So I hope that made it a little clear about what happens to a file in the canal. So let's just pause here, and you guys think that tomorrow when you go, Monday when you go to your practice, that what are those files that are coming to the end of their cycle. So keep a tab on how many users you have. Again, as I said, you must be now, and the most important person to train is your attendant. You got to train your dragon. So you have to make sure that your attendant, who is the most important person, your assistant who's going to be helping you choose the file, that he knows that which file needs to be discarded. Like in my case, I do a tough case, my assistant will throw the file, he will not even tell me. So I know there's a new file coming my way in the next case, because if you start looking at those files being thrown, you will realize that, you might end up reusing a file which you should not have, and that can happen. So when you go back on Monday, look at your endo boxes very, very clearly, understand which file needs to be thrown and throw it first straight away. The act of throwing is more and more important, and start coming to single use files, or keep a tab on how many users you have on your files. So uh, once you separate a file, now what's going to happen? So now we come to the second part of this short seminar, that once you separate a file, what are you going to be doing? The first thing that comes to your mind is not that are you going to bypass it, that are you going to tell the patient or not. So that's a subject of discussion in itself. I feel you should always tell your patients that something like this has happened, and I will, that you will try your level best to amend it, and the best is to refer to an endodontist who does these cases. And or second option is, if you feel you have the skill enough, then you can bypass it. So bypassing is one of the first thing that can come to a mind, that let me bypass this instrument. So it should always be your first choice, because if you bypass an instrument, you don't, there are a lot of other things that you don't have to do to retrieve the file. Now it doesn't require any specialized instruments, and it's more of a tactile based technique. So it's more on the perception that you get in your hand. See, the concept is very simple. The canal is never a perfect round. So there is always going to be some space between the instrument and the canal wall. And that is that space that you're going to be using to bypass that instrument. So that's just showing a case I did, I think 4 years ago, I think. And she moved to Canada. And when I was making this presentation today, I was just putting some different images, and I messaged her and I was like, hi, that it's been 3 years since we've seen you. She's in Canada. She's doing great. She's doing absolutely fine. She's going to come back for her regular checkup. Bypassing, this was I think one of the few cases I have bypassed, because at that time I wasn't very skilled in my microscope. Using my skill sets on my microscope was still limited, if I may use that word, and I was still trying to learn, and I could bypass the instrument. So you can see how with an 8 number file I could bypass the instrument. And that's the 3 month recall. This is 1 year, this is 2 years, and you can see a small gap below the filling, and that is when she went abroad. And so when she comes back, I'm going to be changing that crown and taking another follow-up. So bypassing is a relatively easier thing, your first preference of choice, because that can be managed. Now let me just do a small dive into how you bypass it. What's the whole concept? So take 2 canals which are not round, and let's just throw in some microbes into it, and you take a file which is the cross section is a square or a rectangle, and now you're doing your watch binding and you're pumping it. And same way you take any rotary file, or any which has a cross section of a rhomboid, or any cross section, can be reamer or whatever files that you're using. So the concept is that there is always space between the file and the canal, And that is the space that you end up using to bypass it. Now, it's a very tedious job because it's not going to come, it's not that one instrument is going to do it for you. This is a very magnified image of how it's going to be, but it takes time. You have to be sure that once you bypass, you're in the same path that you have created, that you can bypass the instrument. So it is this space that you have to feel with your instrument within 6 or a C pilot file or a stiffer file, that you can bypass it. And once you bypass it, you would want to be slowly enlarging it so that you can keep the instrument on one side, and then you can obturate the case on the other side. So again, a great way to practice is separate an instrument in an extracted tooth and see if you can bypass it yourself, and then you'll start getting a hang of how easy or how difficult bypassing an instrument is. Now we come to getting a microscope. So that is the skill that you need to have if you really want to, if I may use the word, master this. I feel that everyone learns in this trade of removing instruments, but having a microscope is a most important part because it gives you more control over your working. It gives you more control, and you develop new skills before you start doing this. And as I said, in that case that I showed you, I could not my microscope could not help me much when I was trying to bypass, because I wanted to retrieve, but I wasn't very sure if I could retrieve that case. But luckily, I could bypass in that case. So, what are the different types of procedures that I have used? And these are some techniques that I have used. So, you have direct or indirect ultrasonics, you have BTR pen, you have braiding techniques, you have a lasso technique or the pull technique, and then you have a tube or a cannula technique. I will show you most of the techniques in short bursts so that you can understand what these techniques are. And so these are the ultrasonic files that I use. These are money files. They are very, very cheap files, and you can use them on your scalers, EMS, or satellites. So I use these files for ultrasonic activation. This is from ENDOSTAR. This is a sonic spreader. Again, a very robust system that you can use to activate a file, and I'll show you how we do it. Now, the most important part is that you have to make space around the head of an instrument. Now, how you do that, I'm going to show you is that, so you take a gauge Clayton drill and then you cut it in the center, and you see on the right side of the picture that it makes a platform. So this is called a staging platform, because you need some space around the head of the metal separated instrument to activate it, because you need to expose the head also. Only then though you can start giving these energies, ultrasonic energies, to these files to start loosening and jumping out. So this is how you form a staging platform. Take a gauge. Now this is a classic picture from Dr. Cliff's, this from Dr. Cliff Ruddle, that you take a gauge, cut it into half, and make it. Now again, why you need to see where you're going to be drilling, because you can make a huge ledge on one side, or you can go, because you're removing now a very crucial part of the dentine. So you don't want to be overdoing it. You only want to be doing it so that you can see a platform, a dentine, a space around the head of the instrument where you can activate it using your different types of ultrasonics method, direct or indirect. Now, how do you create a staging platform? Now, you take a gates, you activate the gates, and as you activate the gates, you will liberate more space around the canal lumen. So, if you see the picture on the left and the picture on the right, you can see how a staging platform creates more space around the instrument so that you can see it and move you give your energy to the ultrasonic energy to the instrument. Now, let me show you how it is. This is the same case that I was talking about. Now I am already making a platform with gates 3. I've cut the head of a gates, and I just go in about into short. You can see the mud that is created, that you need to clear this mud. Very, very important, because it's all going to be clogging everything. So you have to make sure that you clear it, the debris, and you have to work under a rubber dam, as I said. Now this is a size 3 mirror, and once I dry it a little bit, I can start seeing the head of. Now there you see, I can see the head of the file. But let me pause it here. Now if you look at this picture, what you can see is that there is more space on the outside part of the head, and the file is inclined more towards more towards to one part of the canal. So it is still not centered, because you need space equal, at least around the instrument. So I have more space on one side and less on one side. So this took a while to retrieve this file, because the head kept on tilting towards one side. And I'll show you how we did it later on. So you see now, if I drill more on that side, that's my danger area. I don't want to be going, because I might cause a perforation on that side. So this is enough for me to drill. I will not be using any further gates and creating a bigger platform, because that's it. I already have space more on one side. And as I said, as you grow more skilled into this, there are not many great clinicians I know in India who would do a smaller staging platform, and then you would still retrieve. So it's all about how much dentin you leave behind that decides the future of the case. You might remove a file and not leave too much of dentin, and the patient might come to you after, say, a year, 2 year, 3 or 4 year, and say that, hey doc, you charged me almost 20,000 for a root canal. Now my tooth has fractured. So you need to weigh in all those pros and cons before you start drilling excessively. And as I said, you become more skilled, you start removing lesser dentin. So all these great clinicians, you see, you hear them of, they're the ones who leave more root canal dentin behind. They're the ones who believe in slimmer preps, not bigger preps, right? So that's the danger area. I don't want to be there too much, and that's where I stopped working. Now, what is the concept of ultrasonic? So the blue part that you see is the file which is in the canal, and the canal is yellow in color. Now, once you put a gates and you give motion to a gates, the gates is going to start cutting around the head, or over the head of the instrument, and then it will make a platform. So now you can see there is a bigger platform, and now you introduce your ultrasonic in that platform, and you start activating the ultrasonic, and slowly the ultrasonic starts, you move it around the file, you keep on moving it around the file, and eventually the head of the file will become visible to you, so that you can grab the head of the file, and then you can retrieve. Sorry, there are too many animations in this, so I sometimes get confused how many clicks to press. I hope you all guys are with me, and if there is anything you can convey, and then the coordinator can message me if there is anything important. So the concept is very, very simple, that you start working around, and now you see you've removed the dentin around that head, and now you have this much area to grab and remove the file, or give direct energy bursts so that the file becomes loose. So this is how direct ultrasonic. Yeah.
To combat before fall down again.
Doctor, sorry for interrupting. Can you unmute? It's on mute, I guess.
Yeah.
Yeah, sir. Now it's audible, sir. Thank you.
Oh, doc, don't tell me I wasn't audible before.
No, it was only for a couple of seconds, sir.
Oh, thank God for that. All right. So, should I go on?
Yes, sir. Yes, sir.
All right. Any query, let me know. All right. Thank you for telling me that. Otherwise, I would not have stopped. And so you can see now I'm just giving energy, moving around. And see one thing very clearly in this video. See that mud that is collecting around that file. It's very important to clear it. And I'm working in short bursts. The setting is not high on my ultrasonic on that instrument right now. So you have to work in shorter bursts. You have to wash it all the time. Make sure you wash it all the time, and so that the aim is to attack the dentin around the file and not hit the file all the time, because if you keep on doing it, your ultrasonic file, the one that you're using, will also separate. And I'll show you something interesting later on. So that's the space that I'm talking about that needs to be, and that is only possible if you have a staging platform. And that's how it is. So that's the staging platform, and now I'm working around, in and around the staging platform, giving energy to the file. All right. So let's come to another video just to show you. Now, slowly look, this is maybe after 10, maybe 5-10 minutes of working, you will now see the head of the instrument starting to move now. There you can see how it moves with the instrument. So now the file is becoming loose in the canal and it's moving, which means it is losing, it's going to come, where it is bound, it's going to give way very slowly. This is a very difficult time because you are literally thinking in your mind that this is the hurrah, and this is the moment that you've been waiting for the whole day, and it doesn't come out because this is the time where it gets stuck the most. And it has to be in the center for for any instrument to come and grab it. So again, giving more energy to remove it, and this is the time I can grab and remove the instrument. But this is just that I want to show you that how it starts to move slowly. It will not move in the first shot. It takes more, so you need to go down further for it to move and disengage. Now, let me show you this case again in a different way. Now, this patient was referred to me and I said, get me a CBCT. And the patient was referred to me for some other reason. The patient was referred because she was having discomfort. The dentist did not know that there was something. So when the CBCT came, the CBCT doctor, the one who had reported the case, had mentioned that it looks to me like a separated instrument, but look where the arrow is. The arrow is right in the coronal part. And I was actually thinking that, okay, if there is something in the coronal I can manage, it will not be that difficult. And I happily took up this case. I said, fine, no problem. Let me take care of this one. Because remember, you never know when you get unlucky with managing these cases. So if you have a protocol, SOPs to follow, then it is easier to manage these difficult cases. So this is how the patient came to me. This is how exactly she came. That's the picture, clinical picture, and the CBCT is what I showed you. You can see periapical lesion on both the roots, mesial and distal. And I thought that if the instrument is right in the coronal part, then I can manage and I can, take care of this case and do an endodontic justice to this case. So as I was trying to, remove and take, as I was trying to remove the instrument, I'll show you a picture, an X-ray of what I did. I separated another instrument in the distal part of it. This is an ultrasonic file that I was trying to, as I said, you can't give too much of energy. So my settings were wrong, or the file had reached its end. There was cyclic fatigue, and because of too much of vibration and hitting the metal instrument, it separated. So I created another problem for myself. But look, what I'm trying to show in this picture is also that look at where the CBCT reporting went wrong. Look where the instrument is. And in my CBCT, that image that I've shown you, there is no instrument. So if you look at this, where they had shown the separated instrument, that's what I thought. It's easy, but in reality, it was here that the problem was. So sometimes, you can go wrong. So you have to be prepared for for the unseen part of it. So this was one case that really, literally tested me. So let me show you a video of this case, and I like to add theatrics to my presentation. So this is a video I made. I really wish removing a file was as easy as this. It's a classic ad from the 90s. As I said, these cases really test your patience. So CBCT had reported this as the file, so there was nothing there. So this is what I thought, and this is what it was. It was a gutta percha rolled and kept like that. So this is what I use chloroform to dissolve gutta percha. This is wicking, and now I am going to be refining the axis, doing some troughing with my tapering burr. Now I can do it because I can see it. That's holds under the microscope. Now this is where the file is. You can now see a shiny head in the mesio buccal, and So you can see there is not too much of space around it. I need to make a staging platform, and there I start prepping for a staging platform. Same concept, what I told you before. I always pack Teflon in the other canal because you don't want it to be jumping out and coming into the other canal. That can happen. So make sure you pack the other canals nicely with the Teflon tape. So this is after a lot of, I think about 2 appointments, it started to move a little bit. And I thought it's almost there, but it wasn't there because I separated another file. And I thought this is me. I had separated my U file, and that's where the extra came. But luckily it was in the coronal part. So I made a loop to retrieve the lasso pull technique. I did wedging action, the tube technique. It wasn't coming out, and with so much of pressure, the clamp came off. So you lose your cool. So you need to have a lot of patience in such cases like this. So again, I went in. As I said, it looks easy, but it took a long time, and there finally it jumped off. And this is a Roeco from Colteen, so it's a micro suction that I take in, and that's where the file. This gives you a lot of happiness when you see these things. Then just put calcium hydroxide, and you will not believe it's been what, 4 months. The patient hasn't turned up. She's traveling and she's comfortable. So hopefully I can show you one day the completed case. So that's one thing. So, and I'll show you another video of how to manage ultrasonic cast posts. So you can also remove posts by giving energy to the post using ultrasonics. This is a very old video. I don't get to see cast posts, but this is how the patient came to me. It's not easy to remove these posts. So first, these are the days when I was just working up with my endo. So I divided the post, and you have to expose the cement lining here. Mesial half came off on its own. Easy. The distal, I was just going to break the cement lining. So this is an ultrasonic Startex tip from Dentsply. It's a workhorse of my clinic, and after few motions of just I'm giving direct ultrasonics to it and cooling it at the same time, and pop, it jumps off. And you can see it coming off. So that's how the post could look like. So now you can retreat the case, and this is how it is. So that's how you can take care of some cast posts also. Now, what is a lasso technique? This is a technique that I learned, and I have my mentors to thank, Dr. Rubin and Dr. Siju, who taught me all this. So this is a lasso pull technique where you can make your own a BTR pen. A BTR pen is expensive. It's almost around 65,000 rupees. But if you get if you get a lot of referrals to your practice, like every week you're seeing a case like this, then it's wiser to invest. But you can make your own loops. So I'll show you how to make a loop. So this is how, just to show you the strength of the loop. So now that's the loop, and as you can see, I put the loop on the file, and I can actually pull the loop, and I can actually remove the file from that. So that much, you can have that. You can give that the loop is so strong that it can actually lift a file up like that. So you can use these loop techniques to remove. Mind you, it's easier said than done, but you should be able to. So you can see that that loop has so much of pressure. I can actually, put pressure on that file and try to put it back. So this is the loop that you can make yourself. Now, BTR pen loops are, of course, better. It's easier to use a BTR pen, but if you get a hang of the loops, you can do it yourself. But if someone wants to invest in a BTR pen, absolutely go ahead. And these loops are really good. And I'll show you a case of removing a file through a BTR loop also. Now, this case for me defines everything, because this case, I will talk you through this case. One of the toughest I did. And look at this case. This case refers to me for a young boy. He's only, so sorry for this. I think he's 17 years old, and he's referred, and there's a file which is beyond the apex. And and there was a massive pathology below. Massive is the word, and this patient is referred to me, and I get a CBCT, and I'll show you the sizes of it. And I told the patient that there is a possibility that I cannot remove this file, so be prepared to go for a surgical part. And I tell my oral surgeon, and he says that, you know, the size of the lesion is extending to below the nose, so below the nasal cavity. So there is a possibility that we might do it under GA. We might not be doing it in the clinic. So, and I imagine me telling all this to a father who just went to get an endo done, and this is what he comes back with. So these are very hard decisions you have to, you have to make. And that's why when these cases come to you, they come with a lot of baggage of emotions, a baggage of pain, distrust. You literally have to win back the trust of your community when you do such cases. And you also at the same time have to tell the patient that, you know, whatever the dentist did, he did good, and he tried his level best and whatever and whatnot. So it's a soup sometimes to be in. Sometimes I'm still learning the art of talking to patients who come to me with such extras. So there we go. What I did. Let's look at the CBCT. The lesion was massive, 12 into 13 into 14.1. There you can see the size of the lesion. And that shiny polestar is this file. So wicking, that's the thing you have to learn. Wick, wick, wick. Take Clorox, take a lot of chloroform, keep on wicking it. As you wick it, you will be exposing the file and removing the. Now I tried braiding technique here. So I put two H files and it did not work. Now I just modified the access again. So the access was so bad that I had to, it was all composite and I wanted to make, so now you can see, but the problem was the head of the file was towards one side. So now that's a BTR pen in place. A lot happened before that. The file comes out. And look at the size of the file. It's a pretty big file. There was an extruded GP alongside it, so that was also removed. I think it was just a lucky day for me. I could manage all this. And that's UltraCal that I placed on that day, and I celebrated. I had a great time. I treated myself actually. And this is after, at the day of obturation, after 2-3 appointments of UltraCal dressings. This is how it looks in a 6 months follow-up. So that is biodentine on the apex. That's a 1 year follow-up. That's biodentine plug, that's fiber post, that's a 2 year follow-up. And there is, you can see almost the whole pathology is gone. And I think this is a 3 year follow-up of the case, 2.5 year, I think. So I told the patient understood this is how it was pre-op. He got another CBCT after 2 years, and this is how it looks now. So there is good bone formation. The case is heading towards, this is again another view. And this is how it looks now. So there is good bone that has come back. So, you know, large endodontic lesions do heal if you give it time, if you give it the right amount of time, the right irrigation techniques, the right disinfection techniques, and you have to, you know, the lady luck has to be on your side also. So this is just an X-ray to show you how it started on the day of observation, 6 months and 2 year recall of the case. And he was so impressed. He was so happy. I was so happy that I could manage this case and I could win back the trust of dentistry back with him. Now, the tube and cannula technique is, what's the time now? It's 9:10. I'll be fast. The tube and the cannula technique is that, you know, there are different things on. You go to dental cart and you will see all these things. IRS is no, you will not see IRS. IRS is not available in India, I think, but it's a tube and cannula technique. Wall dent, safe endo file, endo extractor, alpha dent. All these things. I was just trying to see what all is available. I don't use any of this so far because I've been able to remove files the way in my techniques. So you can use this. If I buy this, I will first try it on an extracted tooth first. So the concept is that there is a drill, and that's going to drill around the head, and then there is an instrument that is going to go into the tube. So, and that's how the file comes off. So these drill sets match Trefines. Again, as I said, I don't use it, but you can try it out. So the concept is that you drill. So the main thing is that the Trefine that cuts, that staging platform, that thing that I was telling you, you do not cut in excess. So there is not too much of dentine removal. So that's the USP. And then there is how the you put the tube on the head of the instrument, and then another one passes through it, engages, and then it removes the file off. I don't have a case to show you because I don't use it. But now, how are you going to remove a fiber post? I think fiber posts are one of If lucky, they are easy to remove because you don't have to remove it. You have to drill right through it. And you cannot do it without a microscope. So you have to identify the head of the post under the microscope. You have to use a narrow carbide burrs like the Comet or the Munch burrs. And you always have to work dry, because if you don't work dry, the fiber post will look like normal dentine, and you will not be able to appreciate. The fiber post looks different under a microscope, and you can see that's going to be looking like a translucent thing, and you can drill right through it. So you have to irrigate to remove the debris. You have to use alcohol 100% to dry it, because if it's dry, you can appreciate where you're drilling, and you drill right through the fiber post, and you drill through the fiber post till the time you don't reach the gutta percha, because you will see an orange glow below the fiber post, and that means you have done your job. There's no way to remove a fiber post other than this. It's easier way to remove, but you need a microscope to do it. This is a newer instrument. I don't know if it's available. I thought it is available, but somehow Zoomax people are not getting back to me on this. This is a dental micro tweezer. So this is a very interesting thing. Once you expose the head of the file, this small thing can go down and catch it like like catching a fish from a pond, and then just clasp it, and then you can remove the head of the file. Now I'll show you a case of this amazing doctor, Dr. Sergio Nicola. He practices in Romania, and he shared this case with us in our group, that how he used this instrument to grab and remove. And so you can see that a micro tweezer grasping the head of the file and removing it. So these are the certain techniques. This is how I practice. This is my room where I practice. I have 3 screens. One screen is to play whatever the patients want to watch, Netflix, Prime Video, Z5s, whatever they want to watch. I play it on the ceiling, so they're distracted. These 2 screens are for my assistants and for me, because they can see what I am seeing. So it becomes easier to work. Of course, this is not ideal. There are ways in which I know clinicians like Dr. Siju and Dr. Gary Carr, the way they practice, they have a practice which is a little different. They have an assistoscope where the assistant is also looking through a microscope. I don't have an assistoscope, but this is what I've managed so far. So maybe one fine day I'll show you a picture with my assistoscope. So this is my practicing room. That's me. That's my Instagram handle. That's called Love for Endo. That's my number. You can WhatsApp me your case. You can WhatsApp me anything regarding this lecture. If you have any comments, you can WhatsApp me directly. That's my email number. So do follow me on my Instagram. I don't post every day, but I do post, and I post tips that I feel can help you. I'm not a very social Instagram dentist, but I like to, present things that I feel could, that I can give it you, so that you can also pick up that skill from me. And remember, guys, the most important thing is that if you keep on being in your, that's my, you can just scan it, and then you can go to my Instagram handle there. One more thing, guys, that remember, if you're in your comfort zone, the magic will never happen. You will listen to this lecture. Saturday, you will binge out, watch Netflix, go to sleep. Sunday, Monday, back to work and back to your life. But that's not how it should be, because till the time you don't come out of your magic, your comfort zone, the magic will never happen. And it did not for me. This slide is not for you. This slide reminds me, this slide has always stayed with me for many, many years. Because from 2009 to 2014, I was in my comfort zone. I was an endodontist, man. I thought I am Shah Rukh Khan of dentistry. I can do anything. And I realized that mundane confidence of mine kept me into my own comfort zone, and I could never enhance my skills. And that's how I came out of it, and I started adding more skill set. And so you have to do it. You have to do it. You have to learn. You have to inspire. Find mentors who inspire you. Stay inspired, because you are the one who will one day inspire people with your lectures. So thank you so much, guys. I will stop sharing my screen. My kids are banging at the door. They're saying where dad has disappeared today. So I'm just going to stop it. Thank you for your time.
Thank you, Doctor. Thank you
Yeah.
for this session. And as we're moving towards the end of the session, we'll have a small question and answer part. Participant has asked a few questions.
All right.
I will just read the questions related to the topic, sir. One of the question is that what size of gates grid and drill need to be used and how to cut them?
Okay, that's a very so the answer lies in what canal you are going to be removing the file from. So you can use. I generally don't go more than gauge 3. You can gauge 1, gauge 2 is more than enough to make a staging platform. The how do you cut it? Just take any burr, pick up a burr from your crown prep and then just cut it into half. So you're going to make and cut it in the center. So you literally chew it off from your burr, and once you do that, you create that flat thing that's going to create a staging platform. But after the staging platform, you should be able to see dentine around that file. So that is what you need. You need a staging platform. If you can't see that, you need to go a step to a gauge higher. But in a curved part of the canal, you have to be very, very careful, because all these cases that I've shown you are the ones where I could see the file eventually. There are cases in which people have retrieved file where, like Dr. Terayuchi, where they cannot see the file, and that's a very difficult case to retrieve. So I have not got such a case so far. That means the file is beyond a curvature. So that is where you have to decide about how you need to make a staging platform. So gates 1 and 2 is for me. That's I would recommend. Any other question that I can answer?
Yes, sir, thank you. And the loop wire number that need to be used.
So there's no loop wire number. No, there's no loop wire. So there is a gold wire that you get from Alibaba. That's how I have it. There is, I'll try to find a link for you. There is a technique on how to make a loop wire. There's no number to it. It's a very, very fine gold wire that you pass through your irrigation syringe, your needle, and you make a loop around it. So if I get that link, I will share with you, doctor, and then maybe you can share it ahead. So there's no number as such to it, but it's just a wire that you get from these online sites, and you can make it yourself. Anything else I can answer?
The size of the needle used.
So that's an irrigation needle. So the one that you saw was your regular that comes with a 2 ml syringe. And if you have a tougher a case in which see, the thing is very, very simple. The only way to remove a file is if that loop can go on top of the file. If it can't go, you need to make a smaller loop. So sometimes that needle that you have, that you get with your 5 ml or 2 ml Dispoman ones are thicker, so you need to come to an irrigation. So I've got two types of loops, one with on my irrigation ones and the one on my regular needles ones. So depending on the case, then I can pick either one of them. Yeah, it's a gold electric wire. Again, as I said, I'll share that name with you. It's a big roll. That roll will last you for a very long time that you get. Which size of ultrasonic tip to be used? Now, there is no size here. If you order money ultrasonic tips, they're about 200-300 rupees that I use depending on how much space you create. So you don't want to be using a 15 or a 20 because they are very thin and they will fracture, they will separate themselves. So you need to be using a 25 to 30. But again, understand the drawback. As you go up, you're going to be removing more and more of dentine. So you know where you have to. So you should be very careful that you don't end up causing a strip perforation, a perforation in the mid root, which is impossible to repair, very difficult to repair. So keep yourself. So I would keep myself between 20 and 25. If I have too much of space, like in a central incisor or on a canine or a distal of a molar, I might use a 30, depending if the file is not jumping out. So these are files I will use once and then maybe twice, and then I'll discard it. So I hope that answers. Then another ultrasonic tip that you can use is the one from Satlac. I think it's called ET5 tips that I have. It's thicker. So you need to use it in cases where you can actually see that it needs a larger lumen, like a central incisor or a distal or a canine one, something like that. That is what I use sometimes, but most of the times it's the Money ultrasonic that I use and the one from Endostar. Those are also they are workhorses. They don't separate that easy, and those are very good files to use. Any other query, Doc? Can cost of ultrasound instruments, dental micro, any company you recommend? Oh boy, that's a tough one. Cost is that's not expensive at all. I use a satellite scaler, and as I said, these are 400 rupee files. Dental micro tweezer is Zoomax. You can Google if you get to know if Zoomax is selling. You can let me know also. I'll also buy it. But Zoomax have it, the micro tweezer. Azure E3 files are good. again, let's not get into which files are good or bad. They're all good, provided you know how to use them. I can give you a Lamborghini and I can give you a Maruti. If you know how to drive, you can drive both of them. So that's how simple it is. Your view on TFRK kit, please. It's excellent if I am a millionaire. I am not a millionaire. I am a dentist who is still making my way up. If I have that much amount of money, I can buy the file retrieval kit from Terayuchi. It's good, but people who have been using it have a lot of good and bad reviews about it. The loop is very fragile. If the loop breaks, the whole kit, it's a waste of, you end up wasting a lot of money. So I don't use the TFRK kit. So whosoever asked me, I think it's Tanveer so you can use TFRK and you can judge yourself. I am no expert to give you opinions. All I know is that it's not a very value for money kit. A value for money kit would be a BTR pen. A value for money kit would be if you know how to make a loop yourself. That's the best value for money because you know you can do it yourself, that loop. So that is what I think. Any other query, Doc? Joule Dent micro tweezer is the same. Excellent, Dr. Anurag. If you can forward it to, you can forward to the rest of the people, then we can also buy it. Ultrasonic with water, without water. Excellent question. I would say ultrasonic without water is how I use it. Short burst, full energy for 1 or 2 seconds, not more than that, because you don't want creating heat in that area. So sometimes I use water, sometimes, but the trick is if you use water, you can't see where you're being activating it. So you can use it most of the time. I use it dry, irrigate, give it a second to irrigate, 3 seconds to irrigate, clean, and then I again come back to my dry tips. Dry working system, working environment. So water I use, but it's just to cool it down and remove the debris. The main is to remove the debris. So I keep on alternating between EDTA to remove the debris, and then I again come back to dry. You can use water, but it's very soon you can't see because the water will end up, your vision is lost in the microscope. Magnification loops. If someone wants to buy magnification loops, in my humble opinion, the ones I have now, I use magnification loops to give anesthesia because I'm not trained to give an inferior alveolar nerve block under a microscope. It's not required, but there are people. Dr. Siju does it. Dr. Gary Carr does it. You need a 6-step microscope to do it. I have a 5-step one. So I use loops which are from a company called Admintech. They are very, very comfortable. And recently, I want to buy loops for my fellow dentist in my clinic, and I tried all different types of loops. To me, the best was Admintech. The comfort, the vision that I was getting, the depth of field, it was really good in Admintech. But there's another company, if I can find out, I'll message you, which was also decent. I'll message you the name. I'm forgetting the name. The dealer is in Delhi. I'll message you the name. So you can, and as far as how much loops magnification you need, well, it's up to you how much you can work with, because as you go up, the loop becomes more heavy. And remember, the loop is all on you right now, so it's difficult to work. So there are these new loops, which are these ergo loops in which you are looking straight and working down. I'm not comfortable because I use a microscope, but I know few people, very skilled dentists like Dr. Vishal in Chandigarh, he uses ergo loops, and maybe a few others. So you see what suits you. As I said, you can choose the car you want to buy, the one they want to drive. Thank you, guys. Anything else I can answer with, please do let me know.
Thank you, Doctor. Thank you for this session and for sharing your knowledge and expertise.
Thank you, my dear. Thank you.
Surely many of us would leave this discussion with amazing giveaway points. And once again, thank you, sir.
Thank
To
you.
know more about our upcoming webinars and workshops, please do check out our website, that is iatpe.org, or you simply can follow our Instagram page and Facebook as well. If you have missed our previous webinars, do check out our YouTube channel as well. Thanks to all doctors for patient listening and your participation for this webinar. Thank you, Doctor. Thank you very much.
Thank you, guys. Enjoy your weekend. Enjoy yourself. Remember, you need to have a balance in your life. Everything is balanced. So, and learn new skills. Rubber Dams Microscope is the way to go forward. Be different, stay different, and have a great day.